माफ कर दे माते. Wait, Shep, I'll come with this.
Hello participants, welcome to SCOMEdipedia Week 2, the week of cardiovascular system or the CVS. We'll have webinars on the CVS, the whole of the CVS. We'll try to cover as many topics as we can. And we'll also try to have some case discussion, quiz and imaging webinar as well. So our first webinar is today and we'll cover the anatomy of CVS and the physiology of heart. So today we'll cover these two topics and I hope you learned something new today. So Sia can take over.
Okay. Hi everyone. I hope you can hear me. So as Nishanta mentioned, we're having our week 2. Today we're going to cover the topics of anatomy and physiology, as well as congenital abnormalities. So we're going to start off, and I'm just going to present my screen. Shreya, you can take over.
Okay, thank you, Sia. But the screen is not visible. So, should I start?
Yes.
So, good evening to one and all present here. Today I, Shreya Nandan, Lomi from SMIMS Sikkim, I'm going to talk about the anatomy and the physiology of the human circulation. So for introduction, we all know that heart is the vital organ that pumps blood to entire body and also helps in the proper working of all the organs by providing them the required energy for functioning. So first we start off by talking about the location of the heart. So the heart is located in the lungs, behind the sternum and above the diaphragm. It's placed obliquely, that is 1/3 of the heart lies on the right side, while 2/3 of the heart is located on the left side. And the size of the heart is approximately as big as the size of our fist, and the weight is approximately 250 gram in males and 250 gram in females and 300 gram in males. Next, we move on to pericardium, which is the protective covering of the heart. So the pericardium layers, that is the fibrous pericardium and the serous pericardium. And both of these layers are continuous at the roots of each of the great vessels, that is the aorta, the pulmonary trunk, the two vena cava, and the 4 pulmonary veins. Now again, now I mentioned the fibrous pericardium. So the fibrous pericardium again is made up of 2 layers, that is the parietal pericardium and the visceral pericardium. And between the parietal layer of the pericardium and the visceral layer of the pericardium lies the pericardial cavity, which is a potential space which is filled up by a serous fluid named as pericardial fluid. Now, the main function of the fluid is the lubrication of the opposed surfaces of the heart so that it allows the heart to function freely without any kind of friction between them. So before we move on to the next topic, that is the sinuses of the pericardium, we need to remember that the heart is made up of 3 layers, that is epicardium, myocardium, and the endocardium, moving from outside to inside. And the epicardium at the roots of the great vessels is arranged in the form of 2 tubes. So first we have the arterial tube, which encloses the ascending aorta and the pulmonary trunk at the atrial end of the heart tube. So there is a mnemonic you can use this to remember. For example, A for arterial tube encloses the A for ascending aorta and pulmonary trunk. Similarly, there's the venous tube. V for venous tube encloses the V for vena cava and the pulmonary veins at the venous end of the heart tube. And the passage between these 2 tubes is known as the transverse sinus of the pericardium. And you can see that labeled, you can see the diagram here that shows a finger passing through the atrial tube and the venous tube. This indicates the transverse sinus. Similarly, we have another sinus, that is the oblique sinus, which is a narrow opening, slit-like opening behind the heart. And its position we can get an idea about its position by the various relations. For example, anteriorly, there's left atrium present. Posteriorly, we have the parietal pericardium, and on the right and left side, this is bound by the reflections of the pericardium. So in this slide, we can see there are the contents of the pericardium, the blood supply, and the nerve supply. And there's an important point that we need to remember in the nerve supply, that is the fibrous and the parietal pericardium that we just talked about, is supplied by the phrenic nerve, which is a somatic nerve, and therefore these pericardium are actually sensitive to pain, whereas the epicardium, that is the layers of the heart, are supplied by the autonomic nerve supply, which is not, and therefore which is an autonomic nerve, and therefore these layers are not sensitive to pain. Now there's a label diagram here which I put in here, which shows the arrangement of the pericardial layers, pericardial cavity, and all the layers of the heart. That is the epicardium, the myocardium, and the endocardium. So now we move on to heart. So we have already talked about the heart as the function and the function as an organ. So it's basically a conical hollow muscular organ which is situated in the middle mediastinum, and the direction of the blood flow from atria to ventricles of the heart is forwards, downwards, and to the left. Now the dimensions of the heart is around 12 into 9 centimeters, and we have already talked about the weight beforehand. So this is a label diagram indicating the borders of the heart, and the borders are being shown here by black colored marker. That is the upper border, right border, lower border, and the left border. This is a slide that talks about the surfaces of the heart. Now, if we imagine the heart in the form of a prism, we can see the various surfaces of the heart. That is the anterior surface, the diaphragmatic surface, the left and the right pulmonary surface, and there's an apex and a base as well. So there's an easy way that we can understand its surfaces. For example, the left pulmonary surface lies in relation to the left lung, while the right pulmonary surface lies in relation, that is very close, and faces the right lung. And similarly, the diaphragmatic surface of the heart rests directly on the diaphragm. Now, we're going to talk about the chambers of the heart. So the heart is made up of 4 chambers, that is the right atrium, the right ventricle, the left atrium, and the left ventricle. So first we'll talk about the right side of the heart and the chambers. Then we're going to talk about the left side of the heart. So first we have the right atrium. It's the right upper chamber of the heart, and it receives venous blood from the whole body, and it pumps it to the right ventricle through the right atrioventricular or tricuspid opening. Next. Now we're going to talk about the features of the right atrium. It includes external features as well as internal features. So starting with external features, this chamber, that is the right atrium, is elongated vertically, which receives the superior vena cava at the upper end and the inferior vena cava at the lower end. So superior means upper and inferior means lower. So that way we can remember this. And there's also a prolonged feature to the left which forms the right auricle, which is an appendage. And there's also some kind of shallow vertical groove which passes from the superior vena cava to the inferior vena cava below. These are known as the sulcus terminalis, which originates from the crista terminalis. You can see the comb-like ridges in here, which indicates the crista terminalis, which originates from the sulcus terminalis. And then we talk about the internal features. There are 3 parts that the chamber is divided into internally. First, we have the rough anterior pectinate part, which consists of transverse comb-like ridges known as the musculi pectinati. And then the smooth part, or the sinus venerum, which is made up of the absorbed part of the tributaries. Then we have the interatrial septum, which forms the boundary between the right atrium and the left atrium. So next we have the right ventricle, which is situated right below the right atrium. So it's a triangular chamber which receives blood from the right atrium and pumps it to the lungs through the pulmonary trunk and the pulmonary arteries. And therefore we can say that the right side of the heart is responsible for the oxygenation of the blood, that is the pulmonary circulation. And internally it's divided into 2 parts, that is the rough inflowing part and the smooth outflowing part. So in this chamber, there are 2 to 3 components that we need to discuss. So first, it has 2 orifices, that is the right atrioventricular or tricuspid orifice, which is guarded by the tricuspid valve, that is the atrioventricular valve, and the pulmonary orifice, which is guarded by the pulmonary valve. Then there's also 3 types of muscular ridges in here, that is RBP, ridges or fixed elevations, ridges, and the pillars or papillary muscles. And all these parts that I described are shown here in the diagram as well. These are the papillary muscles, and this is the rough inflowing part. So next we move on to the left side of the heart. First we have the left atrium, which is a quadrangular chamber situated posteriorly. It has an appendage which is similar to the right atrium, which is known as the left auricle. And then the features are mostly similar to them. And this chamber origin is derived embryologically from the absorbed pulmonary veins, which opens into it. And then we move on to the last chamber, that is the left ventricle, which is one of the largest chamber of the heart. And this chamber receives oxygenated blood from the left atrium and is responsible for pumping it to the aorta, which is responsible for the systemic circulation, that is, supply of blood to all parts of the body. And this chamber also forms the apex of the heart. The features include externally, this chamber has three surfaces, that is the anterior or the sternocostal surface, inferior or the diaphragmatic surface, and the left surface. And internally, this chamber is divided into two parts, that is the lower rough part with the trabeculae carneae and the upper smooth part or the aortic vestibule. There is also two orifices present in this chamber similar to the right ventricle. This is the left atrioventricular or bicuspid or mitral orifice, which is guarded by the mitral valve, and the aortic orifice, which is guarded by the aortic valve. Next, we are done talking about the chambers of the heart. So now we're going to start talking about the arterial circulation, that is the blood supply of the heart. So there are two main arteries supplying blood to the heart, which includes the right coronary artery and the left coronary artery, along with a number of its branches. So some of the major branches of the left coronary artery are left atrial, pulmonary, terminal, and anterior interventricular branch. Similarly, some of the prominent branches of the right coronary artery are posterior interventricular branch, marginal branch, nodal branches, right atrial, infundibular branches, terminal, and the right ventricular branches. Now, there's another point that we need to remember here, that is the cardiac dominance. So the cardiac dominance depends mainly upon the origin of the posterior interventricular branch, which in 90% of cases originates from the right coronary artery, which makes the heart in 90% of cases right dominant heart. And in about 10% of the cases, wherein the posterior interventricular branch originates from the left coronary artery, in those cases, the heart is known as a left dominant heart. So this is a diagram, label diagram, which shows the heart has been divided into different colors, and it shows the various arteries which supplies these parts of the heart, and the short forms has been shown on the left side of the slide. Then we have the venous and the lymphatic drainage of the heart. So there are a number of veins that drain the deoxygenated blood away from the heart. So the largest among all of the veins is the coronary sinus, which is about 3 centimeters long. And there's lymphatic drainage. So the lymphatic drainage of the heart is taken up by two main trunks, that is the left trunk and the right trunk. So the left trunk mainly drains into the tracheobronchial lymph nodes, and the right trunk drains into the brachiocephalic node. So we have reached the last topic of the anatomy, which is the nerve supply of the heart. So there are two types of nerve supply of the heart, supply to the heart. First is parasympathetic nerve supply, and then there's sympathetic nerve supply. So the parasympathetic nerve supply reaches the heart through the vagus nerve, and the sympathetic nerve supply reaches the heart through the spinal nerve, that is thoracic nerves T1 to T5. So now we're going to talk about the effects. So parasympathetic nerve supply has cardio-inhibitory effect by cardio-inhibitory effect, which means it slows down the heart rate, whereas sympathetic nerve supply has cardio-acceleratory effect, which means it increases the heart rate. And there are two plexuses which are formed by the nerves, that is the superficial cardiac plexus and the deep cardiac plexus. So that was it for the anatomy part. So now we start with the physiology part of the heart. So one of the major and the most complex topics in physiology of the heart is the CVS. So, is the cardiac cycle, which I'm going to discuss now. So first we need to talk about some of the basics. For example, so there are two types of basic phases of movement that the heart undergoes, which is the systole and the diastole. So systole in simple terms means contraction, and diastole in simple terms means relaxation of the heart. And there are a few pressures we need to remember. For example, the highest blood pressure or the greatest blood pressure which is attained during systole is termed as systolic blood pressure, which is SBP. And then there's the lowest blood pressure, which is recorded during diastole. It's known as the diastolic blood pressure, DBP. And pulse pressure is the difference between the systolic and diastolic blood pressures. So now we're going to move on directly to the cardiac cycle. So the cardiac cycle, in the form of a cycle, as you can see in the right side of the slide, the cardiac cycle. So all of the events in this cycle move on in a cyclical manner. So we're going to start from one point in the cycle, and we're going to end the cardiac cycle by reaching that exact same point, which will mean that we will have covered all the events in one cardiac cycle. So we start from the point where the venous return, that is the deoxygenated blood from the body, reaches the right atrium through the superior and the inferior vena cava. So as the blood fills the right atrium, the pressure slowly starts to build up in the right atrium, and it undergoes contraction, as we all know. So just before the contraction, you can see the P wave in the ECG in the graph on the left side. Yeah, P wave that we see here. It indicates the depolarization of the chamber, which will lead ultimately to the contraction, that is atrial systole. So increase in pressure in the right atrium, which can be seen in this graph in the atrial pressure curve as the A wave. Okay, so due to systole, the bicuspid valve opens and the blood starts filling from the right atrium into the right ventricle. So bicuspid valve opens, and then there's ventricular system. As blood starts filling up the right ventricular chamber, and the ventricular systole then will proceed. So ventricular systole begins with the isovolumetric contraction of the ventricle, which will start with the abrupt rising of the ventricular pressure. And when the ventricular pressure increases more than the atrial pressure, then the AV valves will close. This phase begins with the appearance of the QRS complex in the ECG, which represents ventricular depolarization. Now, during this time, when the AV valves are closed and before the aortic and pulmonary valves, atrial and pulmonary trunk valves open, the pressure of the ventricles keeps on increasing. This stage is known as the isovolumetric contraction. So the closure of the AV valves gives rise to the first heart sound, that is S1. Then also the C wave is seen right after the A wave in the atrial pressure curve, which is mainly due to the bulging of the AV valves into the right atrium. So, with the ventricular contraction, ejection of the blood from the ventricles begins when the ventricle undergoes contraction, that is systole, ventricular contraction, that is ventricular systole. And this happens when the ventricular pressure increases much more than that of the aortic and the pulmonary trunk. So this leads to the opening of the aortic and the pulmonary valves, and blood starts flowing away rapidly from the ventricles. This phase is known as rapid ejection. And when enough amount of blood has been pumped out of the ventricles, the ventricular pressure decreases and the rate of the ejection slows down. This phase is known as the slow ejection phase. And when the pressure in the ventricle falls sufficiently below the pressure in the aortic and pulmonary valves, then the aortic and pulmonary valves closes abruptly. This leads to the generation of the S2 sound, that is the second heart sound. And the closure of the valves marks, that is the aortic and the pulmonary valves, marks the beginning of the diastole, which is known as the isovolumetric relaxation phase. Although the pressure decreases in this phase, but volume in the ventricle remains constant as all the valves are closed. And since you see that the pressure is decreasing, but the volume in the ventricle remains constant, therefore this phase is known as the isovolumetric relaxation. So the pressure in the atrial valve, pressure in the atrial chambers during this time increases, mostly at the end of isovolumetric relaxation, which is due to the venous filling at the right atrial chamber. Venous filling of the blood in the right atrial chamber. This is represented by the V wave in the atrial pressure curve. So with the filling of the atria by the venous blood, we have reached right where we started in the cardiac cycle, which means that we have reached the end of the cardiac cycle. So now we're going to talk about the volume of the blood ejected during one cardiac cycle, which is known as stroke volume. So the stroke volume is a major determinant of the pulse pressure. And then there's another term known as ejection fraction. So ejection fraction is a percentage of blood in the ventricles at the end of diastole that is pumped into the circulation with each heartbeat. So there are a few factors upon which the stroke volume depends. There are three factors to be precise. They are C, A, and P, that is contractility, afterload, and preload. Stroke volume is determined by three principal factors: preload, contractility, and afterload. Next. So this is a flow chart which shows that the stroke volume depends upon the three factors: preload, contractility, and the afterload. So preload and contractility are directly proportional to stroke volume, which means that if preload increases and contractility increases, both individually or together, it can lead to the increase in stroke volume. But afterload is indirectly proportional to the stroke volume, which means that increase in afterload leads to decrease in stroke volume. Okay, previous slide, see. Okay, so there are two graphs that we can see in this slide. So first we will talk about the slide which is below. So this slide has y-axis, indicates y-axis in venous return along the y-axis and the right atrial pressure along the x-axis. So venous return mostly depends upon the volume of blood in our body. So in cases where the volume of blood increases in our body, which may be due to rapid IV infusion or maybe due to acute cases which leads to increase in blood pressure, will lead to increase in venous pressure, and thus in that cases the graph shifts to the point B, which will lead to increase in venous return and therefore increase in preload. And in cases where there is decrease in blood pressure or blood volume for any reason, for example, if there may be hemorrhage or acute blood loss or shock, it leads to the drop of the, that is a decrease in the graph to the point C, which means that there is decrease in venous return, which leads to decrease in preload. So this shows the factors on which the venous return depends. And talking about the graph at the top, it compares the pressure. It compares the pressures along the y-axis and the venous return along the x-axis. So we can see that the graph at the top compares the pressure in the y-axis with the venous return in the x-axis. And as you can see, upon increase in venous return, with comparatively less increase in pressure inside the chamber, the stroke volume increases. That is, the width of the graph increases. And the fact that the change in pressure and volume are not proportional to each other can be indicated by the hyperbolic nature of the curve. So now we talk about the venous return, which can be defined as the total volume of deoxygenated blood that reaches the right atrium. And it can be approximated by ventricular EDV, that is ventricular end-diastolic volume. There's a clinical note we need to remember, that is the patients increasing massive blood loss, for example, who are trauma patients, whenever they're given large volume of intravenous fluids to increase systemic venous pressure. And this leads to increase in venous return and increase in preload and cardiac output, just as we talked about in the graph. And there's a pharmacological note as well, that is we need to remember. For example, if you give them venous vasodilators, for example, hydralazine, it decreases the preload. Therefore, this therapy can be useful for treatment in case of systolic dysfunction, that is forward failure of the heart. So there are the two other factors on which the stroke volume depends. These are the contractility and the afterload. So contractility is a measure of the forcefulness of the contraction at any given preload. And drugs such as digitalis or sympathetic excitation and heart disease may affect contractility. It may decrease or increase depending upon the situation. And there's afterload. Afterload is the pressure or the resistance against which the ventricles has to pump blood. Then we have the venous system. There are several factors which determine right atrial pressure. It depends upon the balance between the ability of the atrium to pump blood into the ventricle. And then there's tendency for the blood to flow from the peripheral vessels to the right atrium. And it also depends upon the weakness of the atrial wall, which tends to increase right atrial pressure. Then there's some factors which increases the venous return, which depends upon increase in blood volume or increase in tone of the large vessels throughout the body, which means, and there can be dilatation of the arterioles or muscular exercise. So over to you, Sia.
Okay, thank you for that presentation, Shreya. That was really good. So I'm also going to be covering a couple of topics in physiology. So moving on, before I start off, I want to talk to you a little bit about the three basic types of muscles we have, right? So we have the skeletal muscle. One second, let me just get the pointer. Yeah. So we have the skeletal muscle, we have the smooth muscle, and then we have the cardiac muscle. Now, the anatomy of these muscles is very important. They're actually the ones that form the basis for the physiological characteristics of these muscles, right? So these are some things that we have to keep in mind. Now, the cardiac muscle has this feature of excitability. Now, in order to contract, it has to respond to a stimulus. So when it gets a stimulus of sufficient intensity, that causes a contraction of this muscle. So excitability is an important characteristic. And we also have something called autorhythmicity, which is basically when the heart muscle is able to sustain its contraction by means of certain external stimulations from the nerves, the hormones, and the drugs. I'll get to those factors in just a bit. And this very important concept of inotropy. Now, what inotropy means is the force with which the muscle is able to contract, and that is going to differ for pacemaker cells and non-pacemaker cells. I will also be explaining the difference to you along the presentation. And very importantly, we have this structure called intercalated discs. So assume you're in first year, you go on to your practicals and you see the histology slide and you see the cardiac muscle. This is something that you will definitely be able to appreciate. So these are basically bands of muscles that you can see along the irregularly arranged myofibrils. What these are is basically when you have two cardiac cells in the point of fusion between those two cells, you have certain channels, which is really important for ion flow. Now, this ion conductance through this channel is what is the basis for the action potential. Okay, so now the electrical propagation of the heart is very important. It plays an important role in just understanding how everything works. It's also really important for your pathology, because if there's a block in any of these areas, it'll manifest differently, which we'll also learn about in the lectures to come, and also for pharmacology. Okay, so what I'm going to do for this portion of the presentation is I'm going to split it up into two parts. We're going to look at it from a macroscopic view to see what exactly is happening. We're going to break it down to a more microscopic level. Okay, so most of you guys would have heard of the structure called the sinus node. Now, the sinus node is where everything begins. It is the primary pacemaker cell, and it has a high inotropy as compared to the other pacemaker cells. Now, what are these other cells? We have the AV node. Okay, just for the sake of remembering, consider the AV node as backup. So if the SA node is not able to generate those impulses, the AV node can take over. But the inotropy would be lower, so the heart rate would also be lower. The rate at which it will start generating these impulses, the electrical impulses, is going to be much lower than the SA node, and that's going to keep on decreasing as you move down, as you move further down. And we also see these nerves splitting up into two. So these would be the bundles of His and the Purkinje fibers, which go on to innervate the ventricular walls and the atrial walls. Now, I kept mentioning this thing called pacemaker and non-pacemaker cells. Now, what this means is that in your heart, you have these pacemaker cells where everything begins, right? It is these cells that are responsible for that synchronous contraction. They generate these impulses, and that's when you hear this lubbed-up sound when you auscultate, correct? Now, the pacemaker cells would include first off your SA node, second up your backup, which was the AV node, and third would be the bundles. The non-pacemaker cells are the ones that cannot directly generate this action potential, but are very good at propagating it. And that would be primarily your ventricular myocytes. Now, I am fairly certain that most of you have seen this very characteristic graph, but then if you're looking at it right now, you see there is a considerable variation in how it looks, right? So this green graph is what you'd see if a pacemaker cell is responsible. A characteristic thing that you can see, it doesn't have these flat lines. And what that means is that it doesn't actually reach a resting membrane potential. It depolarizes and hyperpolarizes really quickly. That does not take place properly. But this non-pacemaker graph, it actually reaches like this flat line, which is the phase 4. I'll explain that as well. So it reaches that resting membrane potential. Now, before I move on to the more microscopic pictures to see what exactly is going on, I need you guys to remember these three very important ions. You have the potassium ions, you have the sodium ions, and you have the calcium ions. Now, okay, you might want to like think about this a little bit, be a little more creative. So imagine this box over here to be a myocyte, which is your heart cell, like any one of the heart cells. And you see these three important ion channels, okay? So you have to remember this. Within the heart cell, you have a high concentration of your potassium, and outside the heart cell, you have a higher concentration of sodium and calcium. Now, this gradient is what is going to make the ions flow when an actual potential is going to come through. Okay, so in the resting stage, the sodium and the calcium channels are going to be closed. It's only the potassium channels which are going to be open. So you're going to have very high levels of potassium inside the cell. So it doesn't have as many positive ions. So the resting potential is going to be minus 19 millivolts. This would serve as an important MCQ, so you might want to remember that number. So that's what happens in the resting phase. But what happens in the depolarized phase is that you have so what happens in the resting phase? What happens when you have an action potential coming through is that you have depolarization. So this role is going to get reversed. Your pumps are going to start working, and the sodium and the calcium pumps are going to open up. So you have an inflow of the high levels of sodium and calcium from outside the cell to inside the myocyte. Okay, so you have high sodium, you have high calcium, and you have the already existing potassium inside. So that's a lot of positivity within the cell. So our graph is going to move upwards. It's going to be in a depolarized state, and then we're going to have a shifting to a more positive value, and that is plus 10 millivolts. Okay, so this is another graph that I'm sure most of you have seen if you're in first year, and if you're in second year, you must be oriented to these drugs, the antiarrhythmic drugs. Now, these antiarrhythmic drugs act on these specific phases. So they act on these specific ions. That's how they work. So as weird and odd as it sounds, we're going to start with phase 4. Bear with me, it's not phase 0, it's not phase 1. We start with phase 4. Now, phase 4 is a state of resting potential, and that was this, right? When your potassium channels are open and these two channels are closed. Okay, so that is your resting potential, and you understand that the entire everything in our body works to achieve a state of homeostasis. So if something is going up, it'll always end back. It's a cycle. So it'll start with the resting potential, and it'll come back to the same phase 4. It's a cycle. So what happens is when you have an action potential that comes through, you have a state of depolarization. And if you remember, what I said was these two channels are going to open up. You're going to have more ions that start flowing inside. So more ions start floating inside. You have a higher level of sodium. You have a higher level of calcium. And you see this graph moving upwards. That is phase 0. Okay, and then you have the moving on to phase 2, phase 3, where you have rapid depolarization, where these channels are going to start closing, and you have a gradual decrease in the potassium as well. And then it'll come back to the stage of the resting potential, where again, only your potassium channels will be open, and you have the other two channels are going to be closed. Okay, so now there has to be something that is regulating this entire thing, right? We have the sympathetic and the parasympathetic system. So now the sympathetic nerves are going to be under the influence of norepinephrine, and their end goal is going to be to increase the heart rate. And the parasympathetic system is going to be controlled by the acetylcholine, which has the opposite effect. Okay, yeah. So even before you join med school, I'm pretty sure most of you have come across this concept of blood pressure. Like, you've heard this term used really, really often, and we're going to be discussing that in a little more detail because it is really important. So what is blood pressure? So assume, okay, again, be a little more creative. So assume this is your, these are the walls of your blood vessels. Now, whatever pressure that the flowing blood is going to put upon these walls, So the lateral pressure that is exerted by the blood flowing through the walls is called your blood pressure. And as Shreya mentioned, we have something really important in the heart. We have a systole and we have a diastole. So obviously we know that during the systolic pressure, we have a higher pressure overall in the heart. So we're going to measure it to be higher, which would be 120 plus or minus 15 mmHg, which would be the normal value. And a normal diastolic pressure, when we have the ventricles to be ejecting, to have a lower pressure, that is 80 plus or minus 10 mmHg. Okay. So when you have an increase in the blood pressure beyond this normal range, we end up in a state called hypertension, which is a very vital topic, and we will be discussing that along this week. Okay. So as I mentioned, whatever is going on in our body, it has to be controlled by something. It also has to be sensed by something. So when there is a quick change, say millisecond to millisecond between each heartbeat, and if you have an irregularity there are certain reflexes that kick in to make sure there are no irregularities following on. So there are these three receptors that I want you guys to remember. There's the baroreceptor reflex, there is a chemoreceptor reflex, and the atrial reflex. And I'm going to explain this in a little more detail here. Okay, so look at this GIF, and we see these two clean, we see these dots over here. Now these are something called pressor receptors. Now baroreceptor, as you can see from the name, is something that has to be related to mechanics. So the stimulus over here is going to be of a mechanical nature. So when we have so the stimulus is going to be of a mechanical nature. So say within your blood vessel, there is the force with which the blood is flowing is higher. We have a higher lateral pressure that's exerted on these walls. These sensors, which are primarily located in the carotid sinus and the aortic arch, are going to pick that up. There are nerves that innervate this, right? So if this is your blood vessel, there is more blood, it starts to expand, and the nerves that surround this are also going to start getting stretched out. So it's going to start firing action potentials, which go on to relay centrally. So that's what happens near the heart. What happens centrally is that there are three centers that I need you to remember. One is the cardioinhibitory, we have the stimulatory, and we have the vagal centers. Now, these three are going to get either inhibited or stimulated depending on the status of the blood pressure, okay? So assume there is more blood flowing through, these are expanding, you have firing of action potential, they end up centrally. What happens then? There are three centers. Sorry, is there you
a sort of circular structure.
Is there some sort of interruption? Is there any point that you would want to add, or?
Sia, you can continue. I think there was some technical issue.
Okay, I'm so sorry. Right, so these three centers, getting back, so increasing pressure, now stimulated, what happens then? It goes centrally. We have the cardioinhibitory center.
Sia, just a minute. You're not audible.
One sec. Is it still an issue?
No, you're not audible.
I can hear you, Sia, though. Yeah, I can hear you as well.
Yeah, you are audible. So yeah, you can. I think Nishant, I think there is some issue.
No, you're not audible, Sia.
Okay, still, or is it better?
Yes, it's better, yes.
Okay, I'm so sorry for that. I swear this is the last time I'm saying this. So we want to decrease the pressure. We're going to go and activate this cardio inhibitory center, which is going to go and decrease the pressure. Now, a lot of you guys are going to just be like, I don't know what these centers are, and like what is she talking about? So now you know centrally we have the medulla in the brain, which is responsible for functions like these. So now these three centers that I keep talking about are located primarily in the medulla. It's going to be relayed through the to the nucleus of tractus solitarius, and then this is going to go and act. The inotropy will increase, and you have an eventual decrease in the blood pressure. Okay, so that is the baroreceptor reflex. So that is what happens acutely. Now, the chemoreceptor reflex is basically centrally, it's going to go act on the same channels. It's going to have the same end effect, but the stimulus here is going to be different. So chemo, as the name suggests, it has to be something of a chemical nature. So the stimulus over here could be hypoxia when you have a decrease in oxygen. It could be when you have an increase of carbon dioxide, or even with hydrogen ions. So the stimulus differs, but the mechanism thereon is exactly the same. So just like, this GIF is only for the baroreceptor reflex, and the atrial reflex also similar pathway, and stimulus again is just different. So the atrial reflex would be when the atrial fibers are going to get stretched out. So these three reflexes that I have spoken about control the situation in a more acute scenario. So when you have a sudden change, this will take care of it. Okay, I am very, very confident that most of you here have seen this graph, and I'm just going to go through this real quick. This is the last slide, so again, please bear with me. So I told you the final goal is to attain normotension. Normotension is that resting state of homeostasis where we have a normal blood pressure. So what if the pressure goes down, and what will happen if the pressure goes up? Now, if the pressure goes down, when we have low volume or low resistance, it's going to go and affect the kidneys. Now, kidney renin, the liver will secrete this inactive form called angiotensinogen. It's going to get activated, then move on to angiotensin 1. Then we have this really important enzyme from the lungs called the angiotensin converting enzyme, and then that will go convert to angiotensin 2, adrenal glands, aldosterone, and final effect, you're going to have a absorption of water and sodium, and that is going to increase the blood volume. Or it can go act on the vessels and cause vasoconstriction, and you again have an increase in the blood pressure. That is one scenario. But what if we have an increase in the blood pressure? Now, Shreya also mentioned these factors, the preload, afterload, and contractility. Now, these are especially important here. So when you have an increase in the blood pressure, there's going to be a state of volume overload on the heart. There's this very important enzyme called the atrial natriuretic peptide, which will cause vasodilation and an eventual decrease in the blood pressure. So this is what I have to say so far. If there are any doubts, you could please put them up in the chat box. We have a very elaborate module that our local officers have prepared, so please do go through that. We're now going to move on to a later part of the congenital abnormalities. So yeah. Could the next group take over?
Yeah,
sure.
Can you share your screen?
Yeah, so greetings, everybody. After discussing the anatomy and physiology of the heart, which has been nicely explained by Shreya and Sia, now let's move on to the second lecture of the Chronicles of Cardia Week. That is the congenital anomalies of the heart. I am Shan Shah, first year MBBS from Vijay Medical College, Ahmedabad, and my fellow Lomi Siddhika Garg from second year JNMC Aligarh are going to present this topic. So let's begin and hope you like it. So congenital heart disease, or CHD as they are known, is a term designating abnormalities of the heart or great vessels that are present at birth. Generally, they produce no or few symptoms and they go completely unrecognized during life. The incidence rate of CHDs are higher in premature infants and stillbirths. They account for 20 to 30% of all birth defects. Now, the cause of CHD being faulty embryogenesis during 3 to 8 weeks of gestation. Before going into the details of congenital heart diseases, let's take a bird's eye view of the embryology of the heart. So we are getting from this to this. So fascinating, isn't it? Here are some important days that we need to remember. So when does the heart development start? It starts at day 15. The first heartbeat is heard around 5.5 to 6 weeks, and we get a fully functional heart at day 50. So broadly dividing the stages, there are 3 basic stages of cardiac formation. The first being formation of primitive heart tube at week 3, the process of cardiac looping at day 23, and the process of cardiac septation at week 4. We'll discuss all the 3 stages in brief. So first of all, there is formation of heart fields. There are 2 heart fields, the primary heart field and the secondary heart field. Here is the horseshoe-shaped heart field shown here, or the cardiac crescent as it is known. The first heart field is shown here in red, and the second heart field is shown in green. The first heart field will form the future left ventricle, while the second heart field will form the outflow tract, right ventricle, and the 2 atria. So here is a diagram which summarizes entire heart development. At day 18, here is the cardiogenic area in the middle of the head pole. At day 20, the 2 endocardial tubes. At day 21, fusion of 2 endocardial tubes into single primitive heart tube. Here are the dilatations of the primitive heart tube. Starting caudally, the 2 horns of sinus venosus, the primitive atrium, primitive ventricle, bulbus cordis, and truncus arteriosus. At day 23, as we know by now, that there is a process of cardiac looping. So there is a nice mnemonic to remember the cardiac looping. It goes cha-cha slide, box to the left, and love lifts us up. So the bulbus cordis, cha-cha slide, it will move anteriorly, inferiorly, and to the right. Box to the left, the primitive ventricle will move towards the left, and the sinus venosus and primitive atrium will move posteriorly and superiorly. So cha-cha slide, box to the left, and love lifts us up. So at day 35, here you can see the relative adult positioning of the heart, the 2 atria, the 2 ventricle, the truncus arteriosus, and here you can see the aortic arch arteries. Here is a small video to get a better idea of process of cardiac looping. So the 2 primitive endocardial tubes, their fusion into single primitive heart tube, the various dilatations of primitive heart tube, and the process of cardiac looping. So there are certain positional anomalies associated with the heart. The first we'll discuss is dextrocardia. So in dextrocardia, there is reverse bending of the heart tube, which leads to the apex of the heart lying to the right side of the midline of the body. Here you can see the X-ray where the apex is lying to the right of the midline. Here is a baby with dextrocardia. Dextrocardia may be accompanied by an overall reversal of all the organs of the body. That condition is known as situs inversus. And another positional anomaly is ectopia cordis. So due to the deficiency of formation of anterior thoracic wall, the heart may lie superficially. So here you can see the ectopia cordis. Next, we'll discuss cardiac septation. First, discussing about the interatrial septum. So look at the figure A. From the roof of the primitive atrium, there is a sickle-shaped septum, which is known as septum primum. Here is the shunting passage, which is known as foramen primum. Here you can see the endocardial cushion. So before the septum primum fuses with the endocardial cushions, there occurs perforations in the upper part of the foramen primum, which is known as septum primum, pardon me, which is known as foramen secundum. So here the septum primum has fused with the endocardial cushion. Here is the foramen secundum. Now another fold appears from the left wall of the superior vena cava, which is known as the septum secundum. And here is the foramen ovale. So here there is an oblique passage which helps in the shunting of the blood from right side of the heart to the left side. And here is the oblique slit, which is known as foramen ovale. So the deficiency of formation of interatrial septum causes atrial septal defects. Here is a 4-chamber view of an fetal electrocardiogram. You can see the 4 chambers. And here is an atrial septal defect where there is faulty communication. Here is the Doppler view. The complete absence of development of interatrial septum leads to a condition known as quadriloculare biventricular, which means there are 3 chambers of the heart, 2 ventricles, and just a single atria. Also atrial septal defects, as we have discussed. Now there is something known as the propatency foramen ovale, means there is anatomical passage of the probe, but there is no functional shunting of the blood in the child, and usually this closes. But if this fails to close and the foramen ovale is large enough, then there may be functional shunt even in the newborn, which is known as patent foramen ovale. Now discussing about the interventricular septum. Basically, interventricular septum is formed by 3 ways. Contribution by the bulbar septum, proliferation by the endocardial cushion, and the interventricular septum which arises from the floor of the primitive ventricle. So here is the interventricular septum arising from the floor, bulbar septum which divides the aorticopulmonary trunks, and here is the gap that is being left is being filled by the proliferation of endocardial cushion. So we get the interventricular septum. Now the deficiency in formation of interventricular septum leads to quadriloculare biatrial, means a single ventricle with 2 atria, and also the ventricular septal defects. Here is the aorticopulmonary septum. It is a spiral shaped septum. The deficiency of formation of this septum leads to a single truncus arteriosus, which is known as persistent truncus arteriosus, and the failure of the septum to go spiral leads to the reverse positioning, which is known as transpositioning of great arteries and vessels. So here is a video. We have learned about the embryology. Now you can take a look at the normal fetal circulation. I'll play the video and you can accompany me with the diagram. So here goes the video.
The placenta, located in the mother's uterus or womb, allows the passage of oxygen and nutrients from the mother's blood through a membrane to the baby's blood. From here, it flows through the umbilical vein into the baby. With the lungs collapsed, there is no need for the right side of the heart to send blood to the lungs. The blood is already oxygen-rich thanks to the placenta. Instead, there are 2 shortcuts that allow the blood to bypass the lungs. The ductus arteriosus is a structure that detours blood normally routed to the lungs and lets it flow straight into the aorta and on to the rest of the body. The foramen ovale is actually a hole in the middle wall or septum of the heart, which allows blood in the right side to flow through the wall into the left side and out to the rest of the body. In both cases, the lungs are bypassed. Finally, the ductus venosus, which is a continuation of the umbilical vein, serves as a shunt or bypass, which allows most of the blood returning from the placenta to be diverted from the immature liver of the fetus and emptied directly into the inferior vena cava.
All right, so we have the idea of normal fetal circulation. And here are the three shunts that we need to remember in the fetal life: the ductus venosus, foramen ovale, and ductus arteriosus. In the adult life, all the three shunts are closed. The ductus venosus forms the ligamentum venosum of the liver, foramen ovale forms the fossa ovalis, and ductus arteriosus forms the ligamentum arteriosum. Now, having the brief idea of the embryology of the heart, let's come to our topic, the congenital heart diseases. Here are some facts about congenital heart diseases. It's the #1 birth defect, and it is the #1 cause of birth defect related deaths. And here are some other facts. You can take a look. All right. So here is a proposed classification of congenital heart diseases clinically. CHDs are classified into three major categories. The first category being the malformations causing a shunt left side of the heart to right side of the heart, which is also known as acyanotic or pink baby CHD. Second group being malformations causing a right to left shunt, cyanotic or blue baby CHD. And the third group being malformations causing an obstruction in the valves or great vessels. So the pink baby, blue baby, and the gray baby. Here is one of the classification of congenital heart diseases. It is classified broadly into acyanotic and cyanotic. Acyanotic have left to right shunting because of the increased volume of blood in the right side of the heart. According to the Frank-Starling law, the heart will pump the blood whatever amount it enters within the physiological limits. So more blood entering the right side of the heart, more blood pumped into the lungs, and increased pulmonary blood flow. The acyanotic heart disease with increased pulmonary blood flow are atrial septal defects, VSDs, patent ductus arteriosus, AV canal defects. And also acyanotic diseases have another categories that causing obstruction to the blood flow from the ventricles. So the coarctation of aorta, aortic stenosis, pulmonary stenosis are included here. Next up, we have the cyanotic heart diseases. Cyanotic heart diseases have a right to left shunt. So it leads to decreased pulmonary blood flow. Examples being tetralogy of Fallot, tricuspid atresia, and also mixed blood flow. And the examples are transpositioning, total anomalous pulmonary venous return, truncus arteriosus, and hypoplastic left heart syndrome. So if we get a baby, in a newborn baby in the emergency department, here is primary framework for categorizing the congenital heart diseases. If we get an ill-appearing baby, poor feeding, definitely we can suspect septic infections. But another thing that should be high in our differential diagnosis is a congenital heart disease. So here is the blue baby. Early presentation means a baby presenting within 2 weeks of the birth with central cyanosis can be suspected with a right to left shunt. The examples are shown here. Now, how to differentiate between a cardiac cyanosis and respiratory cyanosis? So here are two key points. The cardiac cyanosis increases in presentation while the baby is crying, while the respiratory cyanosis decreases. And another key test is the hyperoxia test, where through arterial blood gas ABG method, we administrate 100% O2. So in the cardiac cyanosis, even after administration of 100% oxygen, PaO2 of the arteries doesn't increase, while in the respiratory cyanosis, it increases. Next up, we have the pink baby, which present between 1 month to 6 months after birth, and generally they have left to right shunting, and they lead to the congestive heart failure. Here are some examples: patent ductus arteriosus, VSD, and AV canal defect. Next up is the gray baby. So classifying this into broadly, the blue baby and pink baby are related with the pulmonary circulation, while the gray baby is related to the systemic circulation. The obstruction in the left outflow tract leads to the gray baby, means there is decreased blood being pumped out due to obstruction, and the examples being hypoplastic left heart syndrome, critical coarctation of aorta, interrupted aortic arch, and aortic stenosis or atresia. So left to right shunt, as we have discussed, it goes from the left side of the heart to right side, keeps on looping and skips the systemic circulation. Left to right shunt results in right ventricular hypertrophy, and it may lead to right-sided failure. Left to right shunt is the #1 cause of right-sided heart failure, and it may also lead to pulmonary hypertension. And once pulmonary hypertension is developed, the defects in this shunt are considered irreparable. The left to right shunts are not initially associated with cyanosis, but over the course of years, patient may develop a reverse right to left shunt, which is known as Eisenmenger syndrome. So here is the congenital left to right shunt. Oxygenated blood recirculates to the lung and doesn't reach the body tissue. The ventricular septal defect, atrial septal defect, and patent ductus arteriosus. Here is the Eisenmenger syndrome, which as we have learned, uncorrected congenital left to right shunt induces anatomical changes that reverse the shunt. So we have a left to right shunt, right ventricular hypertrophy, and blood shunts right to left. Here is a meme to remember the Eisenmenger syndrome. Next up, we have the right to left shunt congenital heart diseases. Means it shunts from right side of the heart to left side. It skips the lung and pulmonary circulation. So the clinical presentations of right to left shunt CHDs are cyanosis, typically while the baby cries or while feeding the baby, paradoxical embolism, hypertrophic osteoarthropathy, syncope, clubbing of fingers, which is really important clinical feature, murmurs, tachycardia. So here is a video.
Signs of cyanosis with congenital heart disease include bluish discoloration of skin and mucous membranes, increased respiratory rate and effort, irritability, or lethargy. Other signs include decreased blood flow to the body, decreased urine output, and metabolic acidosis.
All right, so here the clubbing of finger is shown and a cyanotic blue baby. So there is a mnemonic to remember the right to left shunt. Just remember the 5 terrible T's. The 5 T's: tetralogy of Fallot, transpositioning of great arteries, truncus arteriosus, total anomalous pulmonary venous connection, and tricuspid atresia. The 5 T's, terrible T's. And the third category is the obstruction lesion CHD. Obstruction as in abnormal narrowing of chambers, valves, or blood vessels. So the narrowing of valves we all know is stenosis, or they also may be complete obstruction or fusion of the cusps, leading to a condition which is known as atresia. So here you can see a healthy valve, aortic valve, closed and open, and a diseased aortic valve, closed and open. This is a condition of aortic stenosis. There also be pulmonary stenosis, critical coarctation of aorta that are included in obstructive lesion CHDs. So here are some common facts that will help you. Most common congenital anomaly of heart is the VSD. Most common congenital cyanotic heart disease in newborn is transpositioning of great arteries, while most common congenital cyanotic CHD in children is Fallott's tetralogy, and most common positional anomaly being dextrocardia. Now, having learned briefly about all the CHDs, now let's get into the minute details. I would request my fellow Lomi, Siddhika, to continue. Thank you very much.
Okay, thank you, Shan. Am I audible?
Yes, you are audible.
Okay, good evening, everyone. Now I'll be talking some common anomalies in some more details. Okay. Okay, so the classification was like malformations associated with left to right shunt. It comprises of 3 common anomalies, which is atrial septal defect ASD, ventricular septal defect VSD, and patent ductus arteriosus PDA. So first is atrial septal defect, which means a defect or a hole in the interatrial septum. Now, after birth, there's increased pressure in the left atrium as compared to the right atrium, which leads the blood to flow from left atria to the right atria. Now, the common genetic variation which occurs near a gene, MSX1, which is a strong risk factor which gives rise to this defect. Also, Down syndrome presents in it as a risk factor. Now, there's a term known as Lewton-Paget syndrome. It comprises of 2 defects. First is ostium secundum ASD. Second is acquired mitral valve stenosis. Now, there is acquired mitral valve stenosis. That means blood will not flow fully to the ventricle and to the whole body. Also, there is ostium secundum ASD. So the blood will be flowing from left atria to the right atria. So this creates the increased pressure in the right side of the heart. So the clinical features associated with Lewton-Paget syndromes are fatigue, palpitations, edema, right upper chest pain, and paroxysmal nocturnal dyspnea. Now, types of ASD. It is based on the type of septum involved. Now, you know, in the formation of an atrial septum, 2 types of septum plays a role, that is septum primum and septum secundum. Now, a defect in the septum secundum, which comprises 90% of all ASD, and septum primum defect comprises 5%, and sinus venosus defect also comprises 5%, which is located near the entrance of superior vena cava, which is associated with anomalous venous return. Now, the left side of the slide shows a diagram. Here, B shows septum primum defect, D shows septum secundum defect, and F shows both septum primum and septum secundum defect. Now, patent foramen ovale. Patent foramen ovale is the last step in the formation of the interatrial septum, which normally closes in 80% of people by 2 years of age. But in the remaining, the unsealed flap can open if right-sided pressures become elevated, which leads to this condition, patent foramen ovale. It's also a type of interatrial septum defect. Now, the genetic cause is the mutation in transcription factor TBX5. Now, there's a term known as paradoxical embolism. What is it? This is a diagram which illustrates it very well. What happens is an embolus is formed at the venous end, which goes into the right side of the heart with the flow of the blood. Now, what happens is during pulmonary hypertension, or even or during any strenuous activity, like during a bowel movement, coughing, sneezing, or during Valsalva maneuver, there's a transient increase in the right-sided pressures, which causes right to left shunt. And with this shunt, this embolus goes into the left side of the heart, and it goes into the arterial circulation, then it goes into the brain and to the periphery of the body. Now, in the brain, it causes ischemia over there, which causes damage to the brain tissue, which leads to stroke and migraine-like complications. Now, in the periphery, it causes peripheral embolism and ischemia and damage of the tissue over there. Now, the treatment. The ultimate treatment modality is surgery. For that, we have Amplatzer PFO occluder, which occludes this patent foramen ovale. Also, anticoagulants and antiplatelets present as adjuvant drugs, which decreases the disease progression and also prevent complications. Now, ventricular septal defect, which is the most common cardiac anomaly ventricular septal defect means the defect in the interventricular septum or hole in the interventricular septum. Now, clinical features, this causes the increase in the right-sided pressure, which causes diameter of the pulmonary artery to be increased. Also, pulmonary hypertension can be present. Now, because of increased pressure, there is a pressure in the endocardium of the heart, which may lead to infective endocarditis. Now, risk factors associated with this are Down syndrome and fetal alcohol syndrome, etc. Now, a small defect is repairable by itself, but for the large defect, you need to go to the surgeon. Next, Sean. Okay, types of VSD. Now, it is based on the type of septum involved. Now, interventricular septum is made up of mainly three types of septum: membranous part, muscular part, and the bulbar or conal part. Now, a small hole in the membranous septum, which is the most common, 90%. Now, paramembranous septal defect means a hole in the membranous septum, along with it, the area surrounding it, which creates a large hole. Now, multiple defects in the muscular septum, which leads to muscular VSD, and also conal or bulbar defect leads to conal or bulbar VSD. Now, patent ductus arteriosus. Ductus arteriosus is a duct that connects the pulmonary artery to the aorta. Normally, it closes in 1 to 2 days after birth and forms a vestigial structure known as ligamentum arteriosum, which occurs in response to increased arterial oxygenation, decreased pulmonary vascular resistance, and reduced levels of PGE2 locally. Now, if it does not occur, it leads to this condition, patent ductus arteriosus. Now, a very characteristic clinical sign known as machinery like murmur. You're going to see machinery like murmur on auscultation, which is a characteristic sign. I have an audio. Please play it. Okay. Okay, so pulmonary hypertension and infective endocarditis presents in it as a complications. Now, isolated PDA should be closed as early as life, which is a feasible condition. Now, PDA classification, which is based on the shape of the patent ductus arteriosus, which is conical, window, tubular, complex, and elongated. Now, malformations associated with right to left shunt. Tetralogy of Fallot. Tetra means 4. That means it has 4 pathologies or 4 cardinal features in it. It is a dominant right to shunt. It is the most common cyanotic CHD. Now, 4 cardinal features are VSD, obstruction to right ventricular outflow. That means there is pulmonary stenosis, overriding of aorta. That means instead of arising of aorta from the left ventricle, it arises from the hole that is created via VSD, and the right ventricular hypertrophy. Now, on CXR, you're going to see boot-shaped heart due to marked right ventricular hypertrophy. Next. Okay, here's a diagram that shows the 4 cardinal features you can see. Now, what happens on auscultation, you're going to hear a single loud S2. Okay, now tell me, S2 comes because of closure of which valves? You can post a comment in the chat box. Yes, semilunar valves of aorta and pulmonary. Now, here pulmonary component is weak, so the single loud S2 is only due to aortic semilunar valves. Now, also harsh systolic murmurs are also present. Now, here's a term known as TED spells. TED spells is the intermittent appearance of cyanosis on any strenuous activity like crying, feeding, etc. Now, squatting is an exercise or a technique which helps to contract TED spells by increasing systemic vascular resistance. It increases the afterload against which the left atria has to contract, which increases the tension and pressure over the left ventricle. Left ventricle has to contract, which creates the tension or increase in pressure in the left ventricle. So which prevents the blood flow from the right ventricle to the left ventricle. Okay, TED spells is the intermittent appearance of cyanosis which occurs during crying or feeding. Okay, now I have a CXR which shows the boot-shaped heart, like you see in this condition, tautology of palate. Okay, next. Now, transposition of great vessels. What happens in this ventricular arterial discordance? That means aorta will emerge from right ventricle and pulmonary artery from left ventricle. But there is concordant AV connection. That means right atria join the right ventricle and left atria emptying into the left ventricle. Now, etiology is TG results from abnormal formation of the truncal or aorta pulmonary septa. Now, the blood comes from venous end to the right atria. From there, it goes into the right ventricle. Now, it flows into the aorta from the right ventricle to the aorta, which is a very, very incompatible condition, which is incompatible unless a shunt is there. So, patients with TGA and a VSD often have stable shunt, while with ASD and TGA is unstable, which closes early in life. Now, this condition ultimately leads to right ventricular hypertrophy, and left ventricle may become thin-walled. Clinical features are cyanosis, shortness of breath, and lack of appetite. Now, malformations associated with obstruction. We have coarctation of aorta, which means coarctation means narrowing or constriction of aorta. You can see in the diagram, narrowing is shown. Now, males have more preponderance as compared to females. Clinical manifestations depends on severity of the narrowing and patency of the ductus arteriosus. Now, systolic murmurs or occasional palpable thrills are present on auscultation in this condition. Yeah, now we have two conditions in this. Preductal coarctation with PDA and postductal coarctation without PDA. Now here duct means ductus arteriosus. Preductal means before the end of the ductus arteriosus, means coarctation occurs before the end of the ductus arteriosus. Now this occurs due to hypoplastic formation of the aorta during embryogenic period, which is due to less blood flow to the left side of the heart during embryonic period. Now, it presents early in life. It is congenital. There is right ventricular hypertrophy because now right ventricle has to supply the blood to the whole body via this patent ductus arteriosus. Now, cyanosis is localized to lower half of body. Without intervention, most infants die in neonatal period. Signs and symptoms are pale skin, irritability, heavy sweating, difficulty in breathing, and difficulty in feeding. Now, postductal coarctation without period, which is well recognized in adult life. It occurs due to traumatic injury, atherosclerosis, or inflammation. It is characterized by left ventricular hypertrophy because there is no PDA, so left ventricle has to pump the blood to the whole body against the increased afterload. It is characterized by upper extremity hypertension with weak pulses and relative lower extremity hypotension with claudication and coldness. Signs and symptoms are high blood pressure, headaches, muscle weakness, chest pain. Now, on CXR, you're going to see notching of ribs, which is due to exuberant collateral circulation, which increases the blood in the enlarged intercostal and internal mammary arteries. Also, a figure 3 sign will be there, which is due to pre-stenotic dilatation of aortic arch and left subclavian. Also, it is associated with Turner syndrome. Also, you're gonna see CHF-like symptoms, like congestive heart failure-like symptoms, which is due to unmet needs of oxygen demand in the body. Yeah, for treatment, we have surgical resection and end-to-end anastomosis. Also, interposition graft is there. also patch angioplasty and subclavian flap like modalities are there in the treatment. Now, there's a graph which shows the recovery rate after surgery, which is quite high. As you can see, in adults, it is 99%. In infants, it is 95%. Okay. So here comes to the end of the slide. Thank you. I hope you liked it.
Yeah, so in the chat box, I wanted to ask a couple of MCQ questions that are frequently asked. Any one of you can please type in the 4 cardinal features of Fallett's tetralogy, then it would be great. Can we have some answers in the chat box?
Yeah, Shan, they might just be typing. It will take like 20,
Yes.
30 more seconds.
Yes, sure. Yes, so we have pulmonary stenosis, VSD, overriding of aorta, and right ventricular hypertrophy. Perfect, perfect. Yes, so as we have Fallett's tetralogy, there is also a pentalogy of Fallett. So what do you think is pentalogy of Fallett? Yes, yes, perfect. Tetralogy is perfect. Pulmonary stenosis, overriding aorta, right ventricular hypertrophy, and pulmonary. No, pentalogy of Fallett is basically tetralogy of Fallett plus atrial septal defect. So all these 4 cardinal features plus ASD gives you pentalogy of Fallett. And also there is another confusing trilogy of Fallett. So does anyone of you know what is trilogy of Fallett? Yeah, so trilogy of Fallett is right ventricular hypertrophy, pulmonary stenosis, and atrial septal defect. Yes, perfect, perfect. Pulmonary stenosis, right ventricular hypertrophy, and ASD. Perfect. So these were some confusing questions. Hope you enjoyed this session, and thank you very much for paying attention.
Thank you so much, guys. Guys, if you have any doubts to any of the speakers, you can just type them in the chat box. We will keep that open for 2-3 more minutes so that all of you can ask your doubts if you have any. Or you can also raise your hand and unmute yourself and ask a doubt. Any way works.
Thank you so much for the feedback.
Guys, we have one doubt. Could you please explain preductal coarctation?
Yeah.
Yeah.
Okay, Shan, can we go to the PPT, preductal one?
Yeah, sure, sure. Yeah.
Yeah. So preductal coarctation with PDA. That duct here is ductus arteriosus. Preductal means coarctation occurs before the end of the ductus arteriosus. Now, it is due to hypoplastic formation of aorta in the embryogenic period, which is due to less blood flow in the left side of the heart. Okay, it presents early in life. It is congenital. It is characterized by right ventricular hypertrophy because now right ventricle has to pump the blood to the whole body via this PDA, patent ductus arteriosus. Now in this condition, there is cyanosis, which is localized to the lower half of the body. Without intervention, it is most infants die in neonatal period. Signs and symptoms are pale skin, irritability, heavy sweating, difficulty in breathing, and difficulty in feeding. Is it okay?